Most people who survive a heart attack say the same thing afterward. They had warnings. For weeks, they just did not know that is what they were. A jaw that ached when they walked to the car. Fatigue so heavy after a normal meal that they had to sit down. A feeling of pressure in the upper back they blamed on sleeping wrong. None of it felt like a heart attack. None of it looked like what they had seen in movies. So they waited. And then they did not have the option to wait anymore. This is the video I wish more people had seen a month before they needed it. Subscribe and hit like if you want Medicine Explained the way it actually works. Dr. Lucas Veyron is working toward 10,000 subscribers, and you can move that number. To understand why these warnings show up weeks before the event, you need to understand what is actually happening inside the artery during that month. Because a heart attack is almost never a sudden explosion, it is the final chapter of a story that has been building for years, with a very specific crisis point at the end. The arteries that feed the heart muscle are called the coronary arteries. They run along the surface of the heart and send branches deep into the muscle. Over years, in people with high blood sugar, high blood pressure, smoking history, or chronic inflammation, the inner lining of those arteries gets damaged. Cholesterol and inflammatory cells accumulate underneath that lining and form what doctors call a plaque. The plaque grows slowly over years, narrowing the channel that blood flows through. Here is the part most people do not know. The heart attack usually does not happen because the plaque got so large it finally blocked the artery completely. It happens because the plaque ruptures. The fibrous cap covering the plaque tears open. The contents spill into the bloodstream. The body treats this like a wound and sends platelets rushing to seal it. That platelet clot forms fast, and if it is large enough, it blocks the artery entirely. The heart muscle beyond that blockage stops receiving oxygen. It begins to die. That is a heart attack. The month before that rupture, the plaque is often unstable, inflamed, under stress, and the heart and body are sending signals that something is wrong. The problem is those signals are quiet, unfamiliar, and easy to explain away. The first silent sign is jaw pain or ache that appears during physical effort and disappears with rest. Not a toothache, not an injury. A deep, dull ache along the jaw, sometimes spreading into the neck or the lower teeth, that shows up when you are walking upstairs, carrying groceries, or moving quickly, and fades when you sit down and stop. This pattern has a name in cardiology. It is called referred pain, and it comes from the heart's pain signals traveling up through the vagus nerve and spreading into areas the brain was not expecting to hurt. The heart does not have a direct pain address in the brain, the way your finger or your knee does. When it is starved of oxygen, the distress signal gets interpreted in neighboring territories. The jaw is one of the most common of those territories. The critical detail is the pattern. Effort brings it on, rest makes it go. That is angina, reduced blood flow to the heart muscle during demand until the demand drops. Angina that is appearing for the first time or appearing more frequently than it used to is called unstable angina. It is one of the clearest warnings in cardiology that a rupture event is approaching. The second silent sign is extreme fatigue after activities that never used to cause it. Not tiredness, not the normal drag of a busy week, a specific disproportionate exhaustion that descends after things like climbing one flight of stairs, walking a few blocks, or eating a large meal. When a coronary artery is significantly narrowed by plaque, the heart can usually manage at rest. At rest, oxygen demand is low, and the narrowed artery can still deliver enough. But under any increased demand, the delivery falls short. The heart muscle in that territory starts working without enough fuel. To compensate, the body diverts resources. Circulation to the muscles and digestive system gets deprioritized. That is why a meal can trigger it. Digestion demands significant blood flow. If the heart cannot increase its output adequately, the body feels the deficit as a sudden, heavy fatigue that seems completely out of proportion to what you actually did. People in the weeks before a heart attack often describe this as feeling like they aged 10 years overnight. They stop doing things they used to do without thinking because the recovery feels too long. That progressive withdrawal from activity is a signal, not a normal feature of aging. The third silent sign is pressure, heaviness, or discomfort in the upper back between the shoulder blades. This one is almost universally blamed on posture, a bad mattress, or muscle strain. It presents as a deep, dull pressure rather than a sharp pain. It often appears at the same time as the jaw ache or the unusual fatigue, not separately. The mechanism is the same referred pain pathway. In many people, particularly women, the chest is not where the cardiac distress signal lands. It lands in the back, between and below the shoulder blades, sometimes accompanied by a feeling of heaviness across the upper chest that is not quite pain, more like someone resting a hand there with too much weight. The reason this goes unrecognized for so long is that it comes and goes. It does not feel catastrophic. It does not stop you in your tracks. It is easy to take an anti-inflammatory, feel slightly better, and conclude it was muscular. In a number of cases, that is exactly what it is. But when it appears alongside exertional jaw ache or disproportionate fatigue, the combination changes the interpretation entirely. The fourth silent sign is shortness of breath that arrives without exertion. Breathlessness during exercise is normal. Breathlessness while sitting quietly, while lying down, or while doing something as minimal as getting dressed in the morning is not. When the left side of the heart is struggling to pump efficiently, blood begins to back up into the pulmonary circulation, the blood vessels in the lungs. Fluid leaks into the lung tissue. The lungs become slightly stiff. Breathing requires more effort than it should. This is called early pulmonary congestion, and it is one of the first signs that the heart's pumping function is being compromised. People describe it as not being able to take a fully satisfying breath, like the breath stops just short of complete. Sometimes it wakes them at night and they have to sit up to feel comfortable again. That nighttime version, called orthopnea, happens because lying flat redistributes fluid in the body and increases the load on the lungs. Sitting up drains some of that fluid back down and breathing eases. None of these people think they are describing a failing heart. They think they need to sleep better or lose some weight or check for anemia. By the time they are breathless walking to the bathroom, the situation has moved much further than it needed to. The fifth silent sign is a new pattern of indigestion, nausea, or stomach discomfort that appears without an obvious dietary cause. The heart sits immediately above the diaphragm. The nerve supply to the diaphragm and the upper abdomen overlaps significantly with the nerve pathways that carry cardiac pain. When the heart is under ischemic stress, meaning receiving inadequate blood flow, that signal can land in the stomach rather than the chest. People describe a burning, churning discomfort in the upper abdomen, sometimes accompanied by nausea without vomiting. Sometimes a persistent feeling of fullness or bloating that is not explained by what they ate. Antacids do not help. Lying down does not help. The discomfort comes and goes unpredictably. This is the warning sign that sends the most people to the wrong specialist first. They see a gastroenterologist. They are treated for reflux or gastritis. The cardiac origin is missed because nobody asked about jaw ache or back pressure alongside the stomach symptoms. The warning signs work together. Individually, they are ambiguous. Together, they are a pattern that deserves urgent cardiac evaluation. Now, the 3 questions worth raising with your doctor before you ever need an emergency room. The first is a resting and exercise ECG. A resting ECG captures the electrical activity of the heart at baseline and can show evidence of prior silent ischemic events that left a trace on the heart's electrical pattern. An exercise ECG, where you walk on a treadmill while the heart is monitored, can expose ischemia that only appears under demand. If your coronary arteries are narrowed, the electrical signature of that oxygen shortage often becomes visible on the tracing during effort, even when you feel fine at rest. The second is a coronary calcium score. This is a low radiation CT scan that takes about 10 minutes and measures the amount of calcified plaque in the walls of your coronary arteries. It gives a number. 0 means no detectable calcified plaque. Higher numbers reflect greater plaque burden and therefore higher risk of a rupture event. It is not a perfect test. It does not detect soft, non-calcified plaque, but it is one of the most powerful individual risk stratifiers available, and it is significantly underused in people who are not yet symptomatic but have risk factors. The third is a high-sensitivity CRP blood test. CRP stands for C-reactive protein. It is a marker of systemic inflammation. Plaque that is about to rupture is inflamed plaque. Chronically elevated CRP, even at levels that many labs consider borderline normal, indicates an inflammatory environment that makes existing plaques less stable. Combined with cholesterol numbers and blood pressure history, it fills in a part of the picture that cholesterol alone misses entirely. Here is what to do with this information. Write down whether you have experienced any of these 5 signs in the past month. Jaw ache during effort, disproportionate fatigue, upper back pressure, unexplained breathlessness, unexplained stomach discomfort. If more than one of these is familiar, bring that list to your doctor and ask specifically about the 3 evaluations above. Do not wait for the symptoms to feel serious enough. The whole point of this video is that they often do not feel serious enough until they are. The heart gives warnings. The problem has never been that the warnings do not exist. The problem is that nobody taught you what they sound like. Everything in this video is for informational and educational purposes only. It is not medical advice and is not a substitute for a consultation with a qualified healthcare professional. If you are experiencing any of the symptoms described, please contact your doctor or seek medical attention promptly. Dr. Lucas Veyron's content is designed to help you have better, more informed conversations with your own physician, not to replace that relationship.